Dr. Price.
Good to see everybody. Naomi and Roxanne Rowe, haven't seen you in ages. And Susan Price is joining us today. Good to see you, Susan. Hi. Yeah, so yeah, if you want to put in your chat box your name and stuff, that would be great. All right. Shall we? I guess we can get started. We'll give people maybe another minute. Yeah, so I guess I'll just go ahead with the intro slides while we're waiting for other folks to join in. Thanks for joining us. Free CME, distance technology, online learning, very comfortable from your office or home. Opportunity for case discussion. So let's challenge Sarah with our challenging cases today. And of course, the rest of our interdisciplinary team. And of course, all of us have experience as well. So this is our community of learning. Next slide. Okay, so share your cases. We will teach together and learn together. Any geriatric topic would be fine. It doesn't have to be just today's topic. Next slide. We want to make sure everything is confidential and safe. So all sharing must be HIPAA compliant and a safe learning environment. So we encourage and we don't blame or shame. We've all been there before. Any of these ECHO consultations are not provider-patient relationships. These are just presented as educational opportunities. Next slide. In order to receive CMEs today, you have to complete an evaluation, and that will be put in the link. But as I will mention later, this will be the last one for this from this CME provider. So the HCCME is no longer providing CMEs after the end of this month. So after what, next 2 weeks. So in order to get copies of your own CME transcript for previous sessions, you need to go follow directions in the resource tab of our ECHO website and go to this CME Tracker HMA catalog. And then you can get your own CMEs. Just pull them off the website, and that site will be open till September 6th. And then after that, going forward, starting in January, we will be having CMEs through the Queen's Healthcare System. And so that's where we shift over. Next slide. And then, well, I think you all knew how to use Zoom. Don't forget to use the chat box. Enter your name and others joining the session with you on the same video. And here's our team, our hub team. I'm the course director for this series. Sarah Tompkinson is our social work with 41 years of experience in geriatrics health, mental health, and long-term care. She spent many years at the VA and retired, but then she didn't really retire because she just went on to work at Halikoike and Central Union Adult Daycare, and now she's at Straub, and she's forever. And now she's also with us, with WEP. Never retires, right? No. Tireless, dedicated geriatrics social work. Then Lucas cannot join us today. He's our clinical psychologist. Mary Gotham is our public health nurse, geriatrics, gerontology specialist, but she's retired, but lots of things to share. And we have Chad Kawakami from the School of Pharmacy. Next slide. And just sharing about Sarah, like I said, she trying to retire but can't really, and currently is a part-time social worker at Straub Medical Center and our GWEP social worker for our Department of Geriatric Medicine. They live it, right? She and her husband were care partners for their mother-in-law who lived at home till 103 with the support of her siblings, and she's a care partner for her father living with maladaptive impairment and her mother living with Parkinson's. So she remains inspired by family care partners' commitments, compassion, and caring for loved ones living with dementia. She's also a certified dementia educator and trainer for the TIPA Snow Positive Approach to Care approach. And in her spare time, she loves teaching standing and seated Tai Chi for arthritis and falls prevention. Okay, next slide. And I just wanted to share this, is that TIPA Snow is actually going to be in Hawaii in April. And if you want to see her in action, she does a great webinar, in person and webinar. And she's, I would say, a great performer as well. So teaching us on dementia care practices. She'll be here in April 7th, but registration opens in January, and we'll put up more notices about that. Okay, without further ado, I am going to hand this back to Sarah Tompkison. Thank you so much.
Of course. Thank you for letting us know about that invite for TIPA Snow, and I really would encourage everyone to attend that presentation. It's the last time TIPA was here was probably pre-pandemic in 2019. And besides being entertaining, she just has a wealth of knowledge and professional experience. So what I'm presenting today in part is a combination of what is the positive approach to care that was developed by TIPA Snow. And then I've included also my own professional experiences and tying that in with what we know. So today we are going to be talking about managing challenging situations for dementia care. And the emphasis is really going to be on a non-pharmacological approach. And we'll be doing some interactive activities virtually. So this will be interesting to do as well. So my motto is it's really all in your approach when you work with people living with dementia. And wanted to highlight that our learning objectives in the next 30 minutes is to be able to describe changes in vision that impact a person's ability to a person living with dementia to initiate interactions, respond to efforts to communicate and interact that are initiated by others when dementia is present. And the second objective is for you to be able to explain how to use this hand under hand approach to assist with managing challenging situations, difficult or managing difficult behaviors with not just activities of daily living, but for mobility and to actually also initiate specific tasks and engagement activities. I have to apologize up front. I'm still have braces, and so I'm going to slow it down, but sometimes it's difficult to enunciate because I'll end up cutting myself. So the first thing we need to look at is, as human beings, how do you think we give and receive information? The first way, I want you to take your hand out, is visually. So your thumb is the way that you receive and take in new data. And it's really the king or queen of how we learn information. So keep that in the back of your mind. So when you're coming to actually work with someone, regardless of whether they have dementia or not, when you're greeting a person, you don't want to start being in their intimate space, which is about 1 arm's length. You want to start from about 6 feet, and then you want to make sure you get the person's attention. And still don't go forward unless they recognize and you get their attention. So visual cues is the first thing. And remember to come from the front and be within visual range. And then just gently move to the side, like a 45-degree angle, which is what we call a supportive stance. I actually have a video at the end and some slides to demonstrate that. The second way that we take in information is it's actually through hearing. So the second way is through hearing. So everybody do that. It's your index finger is what we hear, right? But as caregivers, as professional providers, we tend to talk a lot, don't we? And at some point, as we're busy talking and telling the person what to do, all they're really hearing is just this. So we have to really be careful that when we give cues verbally, and like if we give instructions or we're asking something of a person, keep it simple. Just 3 words. Want to eat? Let's go. Be direct. Match your visual cues with what you're verbally asking. Like you're in pain, scared. So I do a lot of that with the clients that I interact with, just to make sure that I'm reading them correctly as well. And most of them have lost language and the ability to express that. The third way that people take in information is through touch or tactile cues. That's 3. Okay, touch. But what would happen is when I want to say that if you approach a person by touching them first without getting their visual, permission to come in, or not getting their attention by speaking to them auditorily, what can happen sometimes is by touching that person, you'll get a fight, flight, or fright response. So when completing a task, make sure that you're also going to explain or demonstrate to the person, again, visually, what you're going to be doing. So when I work with people to do personal care, I'll take the actual brush and I'll show them, we're going to brush your hair. So I show them how I'm going to brush it. And now you. And I'll show you that hand under hand technique. Next slide. So I've talked about vision. It's the most powerful of our senses. And that this is really important. The second bullet point, believe it or not, people living with dementia, they pay more attention to what they see than what they hear. So remember, it's what they see than what they hear. So if they see that you look angry, okay, or you look impatient, what kind of response do you think you're going to get? It's not going to be a positive reaction. They're going to be, again, when they see, they're going to think they've done something wrong or that they've upset you. So again, make everything very simple. We'll talk about how to be aware of people's visual fields. Next slide. I found this very interesting. I learned this through TIPA. So on the left side of the picture, this is inside the hearing part of the person's hearing canal. So the green area refers to what sounds people with dementia are hearing. So the left side is a normal person's hearing. On the right-hand side, it's a person that is living with dementia. So when you look at the green part that's circled, do you see much really difference with how they hear sound? No, there isn't. But look at the bottom in the red. So that part of where the person is hearing, that's a section that addresses how they understand language. And do you see for the person living with dementia in the right side of that picture, there is a big difference. And so that part's affected. So why is it that when we're talking to someone living with dementia, we start to raise our voices? How many times did I have to tell you, Aida? You ate dinner. This is the 13th time you've asked me. So I have to remind myself and other people, they're not hard of hearing or deaf. They're just not understanding what you're saying. Next slide. So this is a big thing for me, touch. People living with dementia need time to process what's going on in their environment. We talked last month about some of those changes in the environment, especially if you're going from home to a hospital setting. There's definite temperature changes. There's different caregivers. There's lighting going on. All this stuff is going on. There's people, it's loud, it's noisy. So transitions of care make it really difficult, not just for people that are not living with dementia, but imagine how much more intense it is, and I guess it's more traumatizing for someone living with dementia. And then there's the sundowning phenomena. So I know when I hear someone in the hospital that's crying out, help me. And sometimes the staff laugh. I just try to watch and observe for a few minutes. And then I go to the staff and the person. I said, I know you're the sitter, but did you ever think just to go over there and talk with the person? Because maybe they're bored. It's 4 o'clock and family's gone home. Maybe they're scared. How much time does it really take to just sit and talk to a person? So hopefully we can start doing that with the sitters, but I'll demonstrate for them. And most of the time, it's just the person is afraid. They're losing track of, or they've lost their sense of time, and what's happening is changing. And also those chemical changes that have gone on in their brain as the day wears on. And so why should we fault the person when we present unwanted behaviors by touching them first without getting their permission, or not even getting within their field of vision? So many times when we're doing personal care, we come from behind the person. We forget that they don't hear us too well, or they definitely don't see us. And so when they get that sudden touch, they do get startled. I mentioned earlier the fight, flight, and fright reaction as a result of unwanted touch. Next slide. So make a note, no touching until you've done a visual or verbal cue. Hey, Chad, how are you? It's Sarah. And you wait to refer. If Chad's not going to respond to me, if he's not going to wave back, if he's not going to extend his arm, should you still keep moving forward? You might have 5 other patients to see to do wound care or to dispense medications, but you still have to give Chad time and space. And you know what? If he's not in the right place, how much harm is it going to do if you come back in 15 minutes and try again? Because I want to do with the person. I don't want to do something to him. That's going to really irritate him. And it'll probably cause more problems for me. So remember, dementia robs skill before it robs strength. I want you to take your hand and look at those first 3 fingers. And OT taught me this is TIPA. These 3 fingers are actually your skill fingers. What do we use the fingers for? We use it for, so that's why they're skill fingers. These last 2 fingers are actually what we call the strength fingers. Sadly, people living with dementia, they lose really the first things to go are going to be the skills. The last thing to go is the strength. So when I grab onto Mary, because she's not coming, I said, Mary, you got to get taking a shower. Your daughter's coming in 10 minutes to take you to the doctor. And I grab Mary by the arm, and then she pulls back, but she grabs me back. You're going to notice with a lot of people, these strength fingers are the things that are going to probably dig into your skin and that. But interesting enough, you know what the 3 fingers also symbolize? Vision, hearing, touch. Okay. So remember, when we as we go on in this presentation, I'm going to show you this technique that TIPA Snow's developed. It's the hand under hand. And it's more than just supporting the person. It actually has a functional purpose. I've been able to use it to help people with eating, with moving, getting them to go somewhere, because sometimes they're stuck and they're like with the Parkinson's patient with dementia. When I start moving with them, rocking back and forth or singing a song, because they still retain rhythm, poetry, and prayer, they actually will start moving. They'll feel that rhythm and move with me. Next slide. So, okay, here's the other activity. I don't know if you can see this. This is about aging and normal vision changes. So for most 25-year-olds, if they stick their hands out, right out to say, everybody do this, because I don't know how many 25-year-olds we have in the audience, and you wiggle your fingers. If you're over 50, you're not really you can feel your fingers. And most of you are probably trying to look either to the side now because you're worried about your vision. You're going to start bringing your hands closer in to, you're going to try to bring your hands in like 160 degrees, which is what most late 40-year-olds or 50 years old. That's like a big, huge beach ball. So for people normally that as they get older and 75 and over, their brain is, the messages they're receiving is slowing down. But if you take that ball into the size of a beach ball, I know it's hard to see this on a Zoom thing. That's about where their field of vision is 120 degrees active sight. Okay, so just keep that in the back of your mind. Next slide. That was normal vision changes. Now, try to think what it's like for a person living with dementia. For the person that generally is probably in the beginning stages of dementia, they are losing peripheral and depth perception. How you know this is for those doctors out there that see their patients, you'll find that some of the family members report, my dad, there's a lot more dents on the car, on the bumper, on the back and the front. I don't know if he should be driving, but he still wants to drive. He's been going to the grocery store down the street for the last 40 years. So that's kind of like one sign that there's vision changes. So for the beginning, early stages of dementia, they're losing 20 more degrees of peripheral active vision, and it becomes more tunneled. So to demonstrate this for yourself, you're going to take both your hands, make the letter C with your left and right hand. Now take the thumbs, put that together, place the thumbs on top of your nose, close the top of your fingers. This is a scuba mask. Okay, now with that scuba mask, how much vision are you seeing to the left and right without turning your head? Did you see Naomi on the crosswalk, right? Did you see on the crosswalk that there's a pothole? Or, hey, in the crosswalk, you're crossing, but there's a car coming over to the right. So unless you know to turn, the person that lives with dementia and has scuba vision is not going to remember or be aware of that change. As you continue, as the dementia continues to progress, it becomes binocular vision. And at this point, you may not be able to see the person that's in front of you more than one arm's length, and it causes object confusion. So if it's time to eat a meal and someone's bringing you a plate full of, mashed potatoes, prime rib, and then there's another plate they just threw at you that's got salad, and there's the drink, it's coming. You can't really see anything else than what's in front of you. And then as it gets worse, the dementia, you end up having monocular vision, right? You can't see much. So I always like to do this activity because it really makes people more aware of what the person living with dementia is experiencing with their vision. Next slide. So now we do have a way that we can try to approach people when that are living with dementia, and it is a positive physical connection and approach. So we're gonna go to the next slide. It starts with us understanding about the 3 zones of space. And again, I talked about this in the beginning. Public space refers to 6 feet or more apart from the other person, but you really don't want to shout to the person that's 8 feet from you. So then to get into personal space, it's 2 arms length distance. And that is equivalent to your arm, stick your arm out, and the other person sticks their arm out. And that's about 6 feet, unless they're really a 7-foot person. And then lastly, the thing we need to be aware about is the intimate space, which is only 3 feet from the person. Okay, next slide. So why are these zones of space important? Because, when we're approaching a person for the first time, which anytime actually, if you're approaching anybody, you don't want to really start with a confrontive stance. It can make people, react in a defensive way. It can scare people. So you see with the supportive stance, the person is actually to the side of the person. That way, the person living with dementia still can see you, and hear you, but it's not where you're right too directly in front of them. Next slide. Stop being too intimate. So we use the hand under hand approach because some of the benefits is it connects you to the person visually. It gives them a sense of control, because really they don't have much control of anything else. So what's the big deal? And it allows you to do with that person, to move them, to change direction. And you're doing it with them and you're not doing something to them. And I like it because it gives me advance notice of possible problems. Um, it's important to remember what the dominant side of the person is, because if you go to the wrong, like if they're left hand dominant or they're left, dominant left side, and you try to do work with them from the right side, it's not really, it's not going to be effective, the approach. Next slide. Yeah, so Renata's question is, but if the person can't see peripherally, and is it really supportive stance? Uh, no, it's not a supportive stance if they really can't see. But let me show you some more videos and pictures. And it's so hard doing this virtually. The truth is, I haven't done this virtually. That's why I enlisted my sister as an actress to help do this. So to make the connection with the hand under hand approach, as I mentioned, you want to be about 6 feet away. I'm getting in the first slide, I'm trying to get the person's attention by placing my hand right by my face. And you notice I'm not waving it down because that can also be a greater distraction and disruption to the person. And then she's checking me out in slide 2. So I'm gonna try to take my hand. I'm gonna try to extend my hand to see if she's going to greet me, and she does accept, my hand. I then slide my hand into her hand in slide 3. Next slide, next picture. And from there, you notice as the caregiver, my hand is supporting her underneath and her hand's on top. And then I move my body to the side. That's sort of a supportive stance. And now I'm in her intimate space. And so far, things are going good. She's still calm. She's not giving a negative reaction. And then I place my hand on top of her hand and I call this the comfort sandwich, because with my hand under her, underneath the palm of her hand, if you do this with someone, it does, and I put a little pressure, there is that comfort. So sometimes I'll do a pump just to comfort the person, calm them down, And from there, I was trying to get her to stand up because we were going for lunch. My left hand then goes to a joint. Usually I'll place it on the shoulder joint or hip joint because that provides security, but I also can use that to direct the person where I'm going. Next slide. I wish we could do this in person, like a live video. Next time we'll do that. So this is just a summary of what I showed you in the last 6 slides. It's pretty self-explanatory. I think the item 6 and 7 here, I wanted to point that really you should, I'm sometimes we forget to say this, but I always will remind myself, they don't remember my name, they don't remember my face, and it doesn't really matter because it's not about me. So I always greet the person, whether or not they're living with dementia. I always greet them the same way. Hi, I'm Sarah. Mrs. Morita, is that your name? How would you like me to call you? Oh, call me Naomi, and then we'll move on. Enter the intimate space and then get into that supportive stance. And then item 8 was what I mentioned about the free hand supporting their shoulder or elbow. Next slide. So this was the little video I tried at my best to do the other week with my sister living with, she's the person that's living with dementia that has Parkinson's, and she was telling me some other things. I don't know. So let's see how the hand under hand technique might work. Hi, Ruth. Good afternoon. My name's Sarah. How are you? Your daughter, JC, just came by and she brought you some fresh moy, huh? Would you like to try some? Place my hand under, get this tool.
And just for the holiday.
I'm helping kickstart her movement because we all remember how to eat. And eventually I should be able to let go.
Yeah.
And the person generally will remember. It's cracking me up, sorry. Okay, next slide. So I love these 5 apology phrases, and it's really helped me personally when I get upset with my parents, and I have to remind myself I'm human. Oh yeah, my sister didn't want to take off the mask. She's a nurse and she's worried about catching COVID or giving things to the patients. So that's why she refused to take off the mask. So here's the 5 apology phrases. I know as a daughter, I'm just trying to do my best. And I know all of us as healthcare providers, that's all it is. We're trying to do our best. So I've learned to have to say genuinely, I'm sorry, mom. I was just trying to help. And you probably weren't expecting me to scold you. I didn't mean to, but it's just sometimes I'm tired and I thought by doing it for you or doing it to you would be easy. But yeah, I'm sorry that I made you angry. That's the second, that's the emotional. I'm sorry that I upset you, mom. I didn't mean to say that. It was mean, it wasn't kind. Please forgive me. And then the third part looks at the person's intellectual capacity, and takes into account, I'm sorry, I had no right to make you feel that way, dad. You're absolutely right. You still can handle, money, going with me to the grocery store. You have a right to choose what poke you want to eat, how much you want to order, and I can see you can pay for that. So next time I'm going to let you do that. And then the fourth looks at experience, where you're able to say, I'm sorry, that should not have happened. I really should not have taken you to the family gathering with 30 people. Because, my dad said, I'm sorry, Sarah. I know I don't know these people. This is like extended family and friends. It was a Christmas party a few years ago. And he was so anxious and terrified. He just shut down. And I felt really bad. And he said, please, Sarah, promise me and tell your brothers and sisters, never take me to a gathering like that again. And I never did after that. I've always made sure that it's people he knows and the number of people that are attending is something mom and dad are comfortable with. But it took a lot for him to say that. And it's taken a lot for me to be able to apologize. And lastly, change that's happening with the person, right? It's really not, again, they're the one that's having to deal with the changes in their brain and not being the same person they were. So if I can understand that and say, I'm sorry, this is hard for you, dad. I really hate it for you. I don't know what that feels like that you can't drive anymore, but I'm here for you. And I'm sorry that we can't let you drive. I'm just so sorry. That must be terrible. Next slide. So here's some final thoughts. And I'd really, as I shared with the panel team, I really want this to be meaningful for people that are attending. And I was saying, I am not someone that's I just have experiences to share. A lot of what I'm teaching and showing you, it doesn't work for everyone. It might work sometimes with that person. And then in the afternoon, it may not. And I like this venue where we're going to always learn from each other. And that's why I value the echo. So the first question is, how has today's presentation changed your thinking about the behaviors and reasons why people living with dementia might be doing what they are doing, especially when you're trying to help? Do you think they're just being stubborn or obstinate? Are they just having a bad day? Or is it their personality? I don't know. The second question is, I think not actually. What are some specific situations where you could practice and use this positive physical approach of hand under hand? And lastly, what can you do when what you've tried doesn't seem to work for your situation? Last slide. So again, we're the people, remember, we're the people with the healthy brains. And the person that's living with dementia, all they really want is for us to be mindful and present with them because they only know what they know in that moment. And they really depend and want us to try to understand. We have to understand what their needs are and what they're thinking, and to be able to try to plan and anticipate that. Watch and observe. Watch what they show you. That makes you the private investigator, how they look and what they say, how they sound, and more important to what they do by their physical reactions. Because until there's a cure, there's only care. Thank you.
Wow, thanks so much, Sarah. That was really powerful. Can tell it came straight from experience.
Still living it, and I'm sure we all are, because the worst part is for everyone in the audience that are healthcare providers. I'm sure you're also taking care of someone or know someone that's living with dementia, and you will most likely get the response from family and friends, well, you're a geriatrician, you know this stuff, you're the experts, come on, tell me, come on, Chad, you have a lot of medications, can't you give something to my mother to stop her from swearing and cussing? Or my dad's so sexually inappropriate, give him something. Have the geriatricians or other nurses had to deal with that kind of response from family members or clients, caregivers of patients? Or maybe I'm just imagining this. And the hardest isn't explaining it to your grandchildren. The hardest thing starts to be when you have to explain it to your children or grandchildren. But my experience now is my grandchildren, this is life. We talk about loving the people in our lives, and this is how we demonstrate our love, because grandma was there and grandpa to help take care of you when I needed the help. And so they're getting a little more involved, but I'm not so caught up with them having to conceptualize what dementia is. And kids are really great because they know how to be present, right? And they're very concrete. So, and they're very forgiving, believe it or not. They're the most forgiving people, children, and they're just want to know what they can do to make grandma and grandpa happy. And I always tell them, well, just being here, even if they say something kind of unusual, it's okay. Other comments? I see some things in the chat.
Yeah, let's take Renata's question. How do we speed this up for people in distress?
Great question, Renata. So if they're in distress, I take the cue, depending on what kind of distress. If it's someone that's agitated and is getting ready to throw things, I'm not going to do no meet and greet, but the key will be to keep them safe, right? And we had a couple of people in adult daycare. She really wanted to go somewhere. So I said, what's the problem? Let's go somewhere. So part of her thing was, and that brought down the agitation, and she was escalating to being combative. But once I said, well, come on, let's go somewhere. It's not a problem. And so we just went outside the gate, and I just walked her around because I know that there's a gated area, and she's not going to move too fast if we had to, and I had a phone if I had to get help. But the meet and greet, it's developing relationships, and everybody really everybody I feel is relational, whether just as human beings, right? We all want to have a relationship with a person. So when you're meeting, greeting, it's just taking stock and assessing where that person's at. It may not just be at that moment. But I did have someone, they had put on a posy vest. That was the problem. She just wanted to walk. What is posy vest on? Well, she's trying to get out. Well, why does she want to get out? Where does she want to go? What does she want to do? We didn't ask her. she's got dementia. Well, let's try asking her. And then, I came and got down on my knees. She was in a Geri church. They're hurting me. I said, they don't mean to. Is there something that you want to do? I just want to get up and go get something from my room. And they watched, and I took her to the room. We sat down on the bed, and I said, but then everybody kind of ran away. And I was going to say, let's try practice doing this. So I don't know. I'm hoping I can do more of it, because I told my supervisor, the vision is we have in every hospital, come on, we all have those patients in acute care that have a sitter, right? Because there are falls risk, they're confused, whatever, but we can teach the sitter things that they can do to interact with the patient for just 5 to 10 minutes. I can create a memory box for each person, or that way you have like, oh, this is what they did for a living. If you're not sure as a sitter what to ask the person, no, Chad was a pharmacist. He actually taught. Can you believe that? He said he was a pharmacist. And go in there and ask Chad, what did you do? I said, you have 2 daughters? But see, that is developing a relationship. That's the meet and greet. Yeah, I see that, Roxanne. Yeah, the physical. Yeah. Yeah. I don't know, Roxy. Roxy, I don't know if you were with me. We had that patient that he was a prisoner of war. I bring this up because in the VA system, we have it's if you don't know their military history or background, and this guy, my POW, it was tortuous. He was a World War II veteran. So he didn't want to take off his socks, to take a bath. I said, so what's the problem? Just let him keep his socks on to take a shower. Oh, but his feet are going to get wet. And the socks are going to get wet. Not a problem for me. Take off the socks later, put on another. And they did that. And he agreed to take a shower as long as we could keep the socks on. I know what Roxanne's saying, though, about families getting hit and struck, every time, and they mean well, especially if they have to do some personal care, like change the depends, right? And you don't want the person to be sitting in stool for a long period of time. It is hard, but again, it's trying to, sometimes I've said, if it's not going to do any harm with the person sitting in their depends for 30 minutes, you may have to come back and try a different approach, and for that poor daughter, yeah.
Yeah,
I
I
don't
think,
know if somebody else. What do you think, Aida?
yeah, I don't know. I have a patient, right? And he's retired. I mean, he's a vet, right? So he has PTSD.
Mhm.
And regularly does not like personal care and physical exams or anything touching him anywhere. That's just the way he is. And I think a lot of veterans
Right.
are that way. So I think what the staff have found, and this sometimes works and sometimes doesn't. So oftentimes you just have to go away and come back later. But we found out that a very, very gentle approach, and the wife gave us permission to use her name. Hey, this is the wife's name, and call him sweetheart and this and just like my lovey something. It worked. I mean, that's what it was a lie, yeah, but
Good.
he responded to his wife, and that was the secret.
Mhm.
So I mean, every situation is different. Not everybody responds to that. So I think it depends. Does anybody else have stories of what worked with this type of person? This. Because I also, know that sometimes, we just have to be very, very creative, and we just have to explore things. And I always say, dementia caregivers are the most creative people in the world. They really have to come up with a new thing every day almost. And they're the ones that sort of know what to do, which is why support groups are so helpful, because they share their ideas and their stories.
I think you picked up on something, Roxy, when you said that the daughter was a trigger for him.
Mhm.
So there might be either there's some transference from maybe he sees her as somebody, he doesn't like, or I don't know in their past relationship what's gone on, with the daughter.
Right. Right. Sometimes we have to swap caregivers, right? They only respond to males.
Yes,
Yeah,
yes.
this other guy, we actually had to do, we had to call him Colonel and then start to use military language. Are you going to disobey orders? And he'll be like, no, sir. Okay. All right.
Yes, yeah.
Everybody's different. Oh, talk of massage for brushing teeth and washing the face. We're not sure it could work with elderly. That's a good idea.
Mm. Mm-hmm. I had someone that would, when they were giving showers in the adult day health, he was always making sexual comments and, he never acted upon grabbing the breasts or other, but and so it made the young, the young nurses aides very uncomfortable. And of course, they tried to talk to him, but nothing happened. And then the wife was very embarrassed. And I said, well, before we give up on this, how about this approach? Guess who has white hair? Let's use me and the other the other LPN. She's got more white hair, and we decided since she was an LPN, they used a buddy system. And believe it or not, when the people with the older nurses came in to help or watch the bathing, he stopped with the language, and first he said, "What are you doing here?" She goes, "Oh, I work with the nurse aide, and so we work as a team, and we help each other." And he just stopped. I said, well, that worked. So a buddy system too.
Yeah, sometimes it's not your fault, it's just it's sort of their trauma informed care, like knowing what triggers them and what they respond to. They respond to males instead of females, or they, respond to
Yeah.
the wife, or they don't,
Or use the grandchildren, the great grandchildren. Oh, I tell you, with my parents, those great grandchildren can do no wrong. They drive me nuts, but they can do no wrong, and I think it's great just to see them. I get to watch that interaction. And my grandson actually, their great grandson's thinking of going into healthcare. So I thought, wow, you're only 11. You sure you want to do this? Well, my mother's a nurse and my maternal grandmother's a nurse. I said, well, I thought you wanted to be an astronaut. You could be an astronaut nurse. But I really think we're missing something with intergenerational teaching and experiences for younger people, because who's going to take care of us, you guys?
Yeah, but I just want to mention that these skills are really good to, I do dementia care all the time, but I just love listening to lectures like this and refreshing, because it also gives me tools to how to teach my family, the patients and their families, and the nurses, aides, and the nurses and the other people who work in the direct care in the front lines, and it helps me give coaching in a way.
Yeah.
Which sometimes, when you're in the thick of it, right, you lose it. You don't think about these things. So
Right.
it's important. So
I don't know, Chad, not to put you on the hot seat, but are medications like is there any quick fix and long-term benefits if you put people on antipsychotics? I hear all kinds of stuff.
Well, I think pretty much be preaching to the choir in terms of the answer to that question is really no. There are no quick fixes without any long-term consequences. I think the consensus probably among the group is that when we do reach for those medications, that it's because we're trying to prevent harm to self or others in the short term. And so we're willing to give up long-term gains for short-term benefit, because there is really like the patient's going to hurt themselves or hurt others. And I think it's very helpful that when you do use those meds, that we have very specific parameters in which we're going to use them, and looking for very specific outcomes, so we don't overextend the use of those meds more than we intended to. But unfortunately for dementia and the related behaviors, I wish we had better things, but we don't.
Yeah, I need to have it specifically, are they psychotic? Is this really this psychosis, this psychotic delusions, this hallucinations causing them distress? They're really seeing the house on fire,
Yeah,
and
those
somebody is
are-
chasing them down the street. Then, yeah, that's a whole different story.
Mhm. Yeah, and and Dr. Tom he chimed in on the chat. He says yes, he uses it as a last resort, and I think in terms of what that last resort is really truly that there's going to be some significant harm to self or others if we don't get that behavior under control. And I think the other asterisk to that is we try to use it at the lowest dose for the shortest amount of time possible.
Anybody have any good stories or pearls to share? Mary, I bet you've seen plenty of stressed out caregivers out there in the home visit world. And I don't know if any of these approaches
Funny,
have,
I can't think of any stories. I guess I'm losing my memory.
I guess I have a
Um,
quick one that I can
I,
share.
I would just say that I wish I knew all of these things, about Tifa Snow and everything back when I was doing acute care back in the 80s. It would have been so helpful with those older patients that we used to put out by the nurses station that would yell all night and everything. So what Sarah's teaching, I feel is very useful. That's all I got to say.
thank you. Michael, were you going to share a story?
Yeah, I was just gonna share a brief story. Hi, everyone. It was a patient who was new to the nursing home, and the daughter was really concerned because the staff had a really hard time getting her mother to take a bath. And I think it was helpful to kind of put in perspective. So I kind of told her, like, think about 70 years ago, how often did people actually take a bath? And she's not really doing that much, so she's not getting that smelly and stinky. So instead of trying to push every single day, like if she has a good day, like certainly positive reinforcement, positive words, like thank you so much for like showering today, don't you feel better and clean? But then also from day to day, not like for the daughter's mindset, she kind of told her how she enjoyed running and how she would get pretty smelly and would want to shower, but like comparing it to her mother who is not doing that, right? And just having her, okay, if she's not going to cooperate with you and want to take a bath the day, you go do your walk, and that may trigger for her like, oh yeah, like my daughter is going to take a shower, I should also go take a shower at some point. So just kind of reframing people's expectations, which Sarah talked about earlier, but that's like an example of kind of reframing family or caregivers' expectations too for what is necessary.
Yeah, I had a patient who refused to take a shower too. And then we decided that we needed to wash the dog, give the dog a bath. So the dog got a bath, and of course he got wet because he got sprayed on. So I guess after that, it was a very easy transition for him to take a shower. It's similar, you got the cues going. Everybody's taking a bath. Great. Anyway, Michaela just put into the chat box that the evaluations are required for CME. So you just go ahead and just click on it right now, and it'll pull up the evaluation form. And so that when we close out, you can have that to fill out and complete, and then you can get those CMEs. This is the last one for this series from HCCME. All right.
Thank you, Aida.
No, thank you everybody for joining us. Good discussion. And hopefully we'll see you again next month. Take care.